Good morning, everybody. How are y'all?
Good morning.
So, since we're going to continue with chapter 3, I'm going to start on pulmonary mycosis, which, if you were following along in the slides, is number 109. First, as I mentioned last Tuesday, I was going to go to the lab and grab a poster, which I didn't get a chance to. So I brought one in this morning just for an idea of what you guys kind of want to do. This one's a little bit extensive, which is not necessarily a bad thing. But your idea is to create a visual display of your project. So you want to be able to use images, you can use text. What you don't want is to have one big picture in the middle and then walls of text everywhere. You want a good balance between pictures and words. You'll see in this example, they put a couple of case studies in there, which is good with the images that kind of went along with each one. So that's about as much wording as you want, as if you're going to put a full case study in. Otherwise, it's just notations, kind of like an outline, essentially. So when someone comes up, they can see the main bullet points of your project, and then you can expand more verbally with them and talk about it. Does that make sense? So some of the major points you want to touch on would be symptoms, diagnosis, treatment, things like that, like the major headlines of what's important for that disease. As you can see, they have quite a lot of information on this, which again is not necessarily a bad thing, but you want to have a good balance between the words and the pictures. Everybody good on that? Okay. Any questions on any of that?
You haven't told us what topic we have yet, right?
So everyone submitted their topics.
Yeah.
If you did not hear from me as of yet, I went through them all last night while I had a 3-second break at work. Everyone is pretty much good. There were only one topic. There were 4 people that chose breast cancer. So I had to email a couple people and let them know that we couldn't have 4 doing it. So I just pretty much went by what time they were submitted. And the 2 last ones that I received were the 2 that I had to deny. But I've already emailed them and they're changing it. Otherwise, everyone else is good if you haven't heard of me. So go ahead and start researching that. Like I said, the library session next week is going to pretty much hone in on how to do that. So she'll go through what sites to use, how to cite specific sources, whether it's online, journal article, a book, things like that. So it's really good to pay attention and show up to those sessions. So you can get that. There's also going to be an assignment she gives you on Tuesday to turn in Thursday. So that will also be part of your, I think it's like 5 points of your grade. But it just to help solidify and show you how to do research and get you kind of in that mode. Any other questions? All right, go ahead and get started. All right, so pulmonary mycosis is essentially a fungal infection of the lung. There's 2 typical causes, either histoplasmosis or coccidioidomycosis. I probably said that right. Coccidioidomycosis. So first off, histoplasmosis. It's from the Histoplasma capsulatum bacteria. These are inhaled spores. Usually only found in the Mississippi and Ohio River valleys. It grows with body temperature. So it essentially needs a relative body temperature of like 98.6 and above to be able to grow. If you have a lower body temperature, it doesn't really sustain in there very well. So it can last over weeks to months to grow. The inflammatory response produces calcified fibrous granulomas that also can have areas of that caseous necrosis, as we talked about on Tuesday, with TV, that Swiss cheese-like appearance, that caseous necrosis in those granulomas. They are usually benign and asymptomatic. This can cause progressive fibrosis in the mediastinum. The scarring that can occur in the chest cavity can cause obstructions in the superior vena cava, the pulmonary arteries, and the pulmonary veins. It can cause narrowing of the esophagus. If that fibrosis continues to grow, it can pinch the esophagus, where difficulty swallowing will become an issue. It can also produce flu-like symptoms. Fever, obviously most infections will cause fever, coughing, sore throat, things of that nature. As I said, they are asymptomatic. About 90% of patients who develop this are asymptomatic. Typically, it is spread via bird or bat droppings that contain the fungus. So, symptoms, as I said, flu-like symptoms, headache, fever, can end up with chills, abdominal pain, muscle aches. The granulomas, as I said, can help, or can not help, but can compress the airway. Can also lead to cough when they build up in the lungs, hemoptysis, dyspnea, or trouble breathing, and chest pain. Radiographically, like some of the other granulomas we've seen, you can see that fluid-filled air spaces in the lungs. It could be just a single area or multiple areas throughout the entire lungs, typically in the lower area. You will see hilar lymph node enlargement, mainly in children, whereas in adults, you will see calcification of those lymph nodes. There will be a circular drain.
Sorry, I just want to so does the fungus cause the granuloma? Granuloma is that cancer or?
No, these are benign. So just because there's a granuloma doesn't mean it's cancerous.
Okay.
The granuloma is just essentially a sac of diseased tissue, if you want to think of it that way. Does that answer that question? So as I said earlier, there'll be circular granulomatous nodules in the lower lobes, is where you're typically going to find this. So you can see here, there's your hilar lymph nodes, the left and the right. There's a full chart that goes along with this, but it's not attached because I really just wanted the picture so you can see where those lymph nodes were located. Here you can see that area right here along the mediastinum on the left side. This is going to look like a popcorn or snowball pattern. You can see here it almost looks like it could be like a little popcorn kernel or almost like a regular snowball shape, kind of cloudy. They are typically less than 3 centimeters. You can also see another one right down here. A little smaller. There. Here's that snow. They call it a snowball pattern here, but it's more like a snowflake pattern as well. So it can lead to a lot of scar tissue in the lungs on future images. So when they do the repeat images, these will show up as scar tissue on those images. It can also resemble TB. So a lot of other, just an X-ray is not going to determine what this is. There's going to be other testing involved with this, so that they know it's not TB and it's this infection. Coccidioidomycosis. It's from the specific spores, the same name. These are native to the San Joaquin Valley in California, whereas histoplasmosis, as I said, was native to the Mississippi and Ohio River valleys. This is pretty much native to that San Joaquin Valley in California, which is southern California around San Diego area. It's most commonly acquired in the summer or late fall, mainly during most outdoor activities where it gets picked up often in the drier climates. People with low immunities are more at risk. This can be acute or chronic, meaning they will have symptoms immediately when they get it, and then they can kind of dissipate, or they will just have symptoms for a very long period of time, and they never really go away. Again, these are going to be flu-like symptoms: headache, fever, cough, fatigue, sore throat. About 60 to 65% of these cases are asymptomatic, where distal plasmosis is about 90% of the cases that were asymptomatic. The primary infection with this is in the lungs. Doesn't really travel anywhere else. In chronic infections, they will end up with lung abscesses as well. And then if those abscesses rupture, they can cause mediastinal infection as well as other cavities in the area. But in general, it acts very similar to distal plasmosis. Radiographically, you'll see some small pulmonary consolidations in the periphery, in the parenchyma. This can progress to pneumonia or other chronic lung infections. See if these are not nodules, those are EKG leads. But here is that nodule. This is in the upper left lobe, where histoplasmosis was primarily in the lower lobes. This can be up in the middle or upper lobe. See, there's a very large lesion on the right-hand side, then those alveoli. And you can see that cavity where an abscess had formed. Again, there's that cavity as well on the CT. Here they have all of the lesions all over. These are not cavities. This is actually a very perfect slice through the main bronchioles. Use that for the cavity. Treatment-wise, this is essentially for both. There's about a 1% that require actual drug treatment. Typically, bed rest is for both of these patients. They may also give them lung therapy exercises to do. If anyone's seen anyone up in the room, like doing chest x-rays that have that little white tube on the side with the hose that they blow into, just have them keep doing that. That essentially helps open up the airways, open up the alveoli, stretch all that out. So we'll be doing that. Some of the drugs they'll use itraconazole, or more commonly, amphotericin B. And then for Foxy, they'll do antifungal therapy. They can do some debridement. If there are those lung abscesses, they need to get them out and cleaned out. And depending on how other things go, if those abscesses get too big or they rupture, then they have to do lobectomies, things like that. RSV, respiratory syncytial virus. So this is most common in children under the age of 4. Affects almost all children by the age of 2. However, that is not a end-all be-all. There are some elderly adults that can contract it as well if their immunity is low throughout the back. But primarily it is a virus of children. Less than 2% require hospitalization. It does lead to bronchiolitis. About 80% of all bronchial inflammations are due to RSV. The virus typically attacks the lower respiratory tract, not so much the upper. It can cause necrosis of the epithelium in the bronchi and bronchioles, where that edema can then form from obstruction of those bronchioles. Here's our bronchial swelling. You can see it starts closing off, and that can then cause edema. It can also lead to bronchial spasms and interstitial pneumonia. Symptoms will include cold or flu-like symptoms, you'll see fever, headache, chills, coughing. It is transmitted through droplet. Radiographically, you'll see hyperinflation of the lungs, diffuse increased interstitial markings. The bronchioles will be more visible. Essentially, they'll have an increase in their density. You'll see areas of atelectasis, depending on how far the virus is spread. Necrosis of the epithelium, as I mentioned before, which can then lead to that interstitial pneumonia. Here, that little circles are the EKG lead, called all this patchy appearance right down here. With that interstitial pneumonia starting to form. Treatment-wise, there's no real treatment that's needed most of the time. Just like any cold or flu virus that will just pass normally on its own. If there are any other infections that take place, they can put on antibiotics. They may need antiviral drugs, depending on how far it goes through. So the one antiviral they will use is ribavirin aerosol, almost like a nebulizer treatment. Help clear the airway. They do oxygen therapy, and then in very, very severe cases, they will have to be mechanically ventilated. SARS, or severe acute respiratory syndrome. So the first case of SARS first appeared in China back in 2003. There was a global outbreak. SARS is a coronavirus. It is of unknown origin. So we're not talking about the current one. This is the one back in SARS-CoV-1. So again, it is droplet transmission, person to person. Does affect the upper and lower respiratory tracts. Usually starts with a non-productive cough, and then can lead to hypoxemia. May require intubation and mechanical ventilation. 3% of these cases were fatal. It is very similar to pneumonia. And there are typically two stages. There's the beginning stage where it's just very mild symptoms, fever, slight cough. And then the second stage is where it progresses to a full-on pneumonia where they will need ventilation. Radiographically, you're going to see some patchy appearance in the lungs due to that infiltration. And there will also be a ground glass appearance in certain areas. So here, this is 5 days after the start of symptoms. You can see that ground glass appearance kind of in the periphery of both lungs. So these are images of a 34-year-old female with SARS. So in this image, it's a PA projection 3 days after fever onset. You see that little opacity here. And then this was 4 days. So essentially the next day, you can see how large it grew with that infiltration and that opacity of that area. So here, this was 8 days after onset. You see that parahilar opacity of farms progressed, as well as the lower areas of the lungs here. And then just a day after that, 9 days later, you can see how far the lungs have been infected. So it moves very, very quickly. Again, here this is 10 days after. This patient would have been intubated already. You can see the ET tube right here. That patient did expire on that 10th day after onset. Treatment-wise, they'll use antibacterial drugs to treat the pneumonia. They'll use antiviral drugs to treat the actual virus. They'll use steroids to help reduce tissue swelling in the lungs. And then they'll use a lot of oxygen therapy to try to keep that patient regulated. Diffuse lung diseases. We talk about COPD, or chronic obstructive pulmonary disease. This is the 4th leading cause of death in the U.S. There's chronic inflammation responds to bronchi, bronchioles, alveoli. It's essentially an obstruction of the airway, leading to that ineffective exchange of those gases. Oxygen in, carbon dioxide out. This makes breathing very, very difficult if they cannot exchange those gases. Especially they can't get O2 into the organs, or the lungs, or the heart, and blood. They can't expel carbon dioxide, so it just kind of keeps circulating in the machine, poisoning all of the people. COPD can include chronic bronchitis, emphysema, and some forms of asthma that are also related to the first two. Chronic bronchitis essentially is a chronic inflammation of the bronchi. Does have a lot of mucus production due to thickened walls in those bronchi and bronchioles. It then leads into the trachea as well. Can lead to obstruction of the small airways. You can see here the normal bronchi, nice open and clear. Bronchitis, all that inflammation and mucus builds up and will cause obstruction of those smaller airways. To make it chronic bronchitis versus acute bronchitis, you have to be suffering symptoms 3+ months out of the year for 2 consecutive years in order for it to be considered a chronic. I don't know why they figured those specific numbers, but it's a lot of them. So causes of chronic bronchitis can be any sort of virus or bacteria that gets into the lungs, air pollution, and cigarette smoking. Cigarette smoking is about 90% of the causes of chronic bronchitis cases. The severity and recovery of chronic bronchitis in smoking patients depends on essentially how long they smoke, how much they smoke, depending on how quickly they can recover. Who's most at risk? Smokers. Treatment-wise, they'll do prophylactic antibiotic therapy, bronchial dilators, and expectorants to help try to clear all that mucus out. Radiographically, you're not going to see any sort of change in imaging in about half of patients. Some patients, you can see some thickened bronchial walls, or some narrowing airways, also termed tram lines. It's essentially a slightly tapered tubular fine shadow. The narrowing of the airways can also cause overinflation of the lungs and look almost as if they have emphysema. You can also see a depressed diaphragm. So you can see here, it is all infiltrate inflammation inside the bronchioles. You should really see them all this clearly. Here. Emphysema essentially destroys the alveoli or the air sacs. Usually follows chronic bronchitis. So you have the inflammation, the thickened walls, increased production, and if it goes on long enough, it can move into emphysema with that destruction of those air sacs. This leads to loss of elasticity in the lungs, meaning they can't bring in or push out air as easily. When those air sacs get broken, that also reduces the surface area of the lungs, which reduces the amount of oxygen that can be pulled in and sent into the bloodstream. So how it happens is when you breathe in, you can't expand the pull in oxygen, and when you breathe out, the elasticity is not there to hold, so they don't completely close when you breathe out. It's almost like a blood pressure cuff. You can collapse it when you push the air, but it doesn't fully close at the end. Here, when it collapses, it fully closes, so it doesn't actually let the air push all the way out, so then that CO2 gets trapped on the inside. So again, narrowing of the bronchioles and loss of elasticity, that leads to air trapped in the lungs, which then leads to that destruction of the alveoli walls, and then leads to bullae formation, and then loss of surface area. So each of these large areas is considered that bullae. So with that loss of oxygen in the blood, the heart then has to overcompensate and pump harder to try to get oxygen to the areas of the heart as little as you can. So it pumps harder, puts more strain on the heart. When those air sacs rupture, it then can lead to air in the pleural space, which then is a spontaneous pneumothorax or collapse. There are three morphologic patterns with emphysema. So you have centroacinar, which is only the central portion of the sinus. Paracinar, which is the entire alveolus distal to the terminal bronchioles. Or distal acinar, which is the distal airway structures, alveolar ducts, and sacs. So they'll label it, determine where it's located in that bronchial system. Causes, again, chronic bronchitis, long-term exposure to air pollution, long-term cigarette smoking. Who's at risk? Again, cigarette smokers, pipe and cigar smokers. Occupational is if anyone's working with any industrial chemicals that get burned off in the air or live in areas of high air pollution. Or people who have AAT or alpha-1 antitrypsin deficiency. Treatment for this, prophylactic antibiotic treatment or therapy, bronchial dilators, expectors to help fill anything out. Alright, so radiographically, you're going to end up seeing some overinflation of the lungs, which then means flattening of the diaphragm. You see here it should be nice and rounded on both sides. It's pretty flat. You can also get the barrel chest shape. You have that flattening of the diaphragm here, and it widens the entire area. You have that barrel chest appearance. That bullae formation, as I said, is all those ruptured air sacs. So also you're going to see, have any of you seen a sniff test? So a lot of that, most of that is done to determine paralysis of the diaphragm. They'd also do it in these cases to see if the diaphragm actually can create a dome or not, or if it's going to stay flat in that case as well. Causes can be hereditary, as with osteogenesis imperfecta. Patients with that can also have asthma. Is just a narrowing of the airway due to swelling. It's usually a response to allergens, or if it is a response to allergens, dust, mold, animal danger. This is termed an extrinsic response. If it is due to exercise, heat, or cold, or any emotional issues, it is termed an intrinsic response. So if it's anything outside of the body, extrinsic, anything inside, so is an allergen, or if it's intrinsic, gets through the body and then cause that inflammation of the airways, swelling of those mucous membranes, and then increased mucus production. And what you see here is a low bronchial, an asthmatic bronchial, you see a lot of inflammation and mucus production, closing off that airway. These patients find it very, very difficult to be able to expirate. They will have a lot of wheezing. And if left untreated, you can actually get scarring in the bronchioles to where they don't actually function correctly. Again, you have those extrinsic and intrinsic causes, as I mentioned earlier. Treatment, bronchial dilators, allergy shots, inhaled steroids will help keep those bronchioles open through that mucus. Symptoms, cough with or without sputum, shortness of breath, wheezing. Radiographically, so you're not going to really see anything in the early stages. It'll look nice and clear. As the asthma reaction goes along longer, you can see increased lung volume, flattening of the diaphragms, and fibrosis, or what's termed dirty chest. So that fibrosis is just from that thickening of those bronchial walls over time. That's typically a chronic issue. Here you can see that flattening of the diaphragm, that barrel chest appearance, unable to get rid of air or increase that lung volume. Here's that dirty chest from all that fibrosis, chronic asthma patients. Bronchiectasis, Again, this is caused by chronic lung infections, such as cystic fibrosis, for instance. It is destructive and widening of the large bronchi. So it's not, you see here, again, you have the normal airway, again, the inflammation and the mucus production. Can cause permanent abnormal dilation of one or more of the large bronchi due to that loss of elasticity in the bronchial walls. The bronchiectasis can lead to bronchitis and then to bacterial infections due to impairment of the body to be able to clear and expel and get rid of inflammation like this. Cause is typically the recurrent inflammation and infections. Can begin in childhood. Usually involves the basal segments of the lower lobes, typically bilaterally. Treatment-wise, they'll do certain vaccines for bacterial or viral infections. They'll also give antibiotics for infection. They'll also use like oxygen therapies, things of that nature. Symptoms, again, with most of these, it's chronic cough or sputum, hemoptysis, shortness of breath, wheezing, can end up with recurrent pneumonia. Radiographically, you can see what's termed a honeycomb pattern, which typically will be in those lower lobes. You see those coarse interstitial markings with that bronchial fibrosis. Here on the CT, you can see what it looks like cross-sectional, which is why it's called a honeycomb pattern. Sarcoidosis. So essentially an inflammation in the lymph nodes, lungs, liver, eyes, skin, and other tissues. But the lungs is the most common site. Essentially with this, if you're talking about what granulomas are, they pretty much form in these organs that it attacks due to the immune cell response. So here's some magnified view. Here's healthy lung here. Then it turns into alveolitis. Once it gets into the alveoli, then you have that granuloma formation, and the scar tissue essentially starts to form, and then full on to fibrosis. So who's at risk? African Americans are about 10 times more likely than Caucasians. Women are 2 times more likely than men. Typically ages 25 to 35, and then anyone who has family history of sarcoidosis. So here's a little chart that shows where it can actually start. We said the lungs were the most common, but it can affect the brain, the eyes, salivary glands, lymph nodes in the neck and chest, the heart muscle, skin lesions, spleen enlargement, liver enlargement. So it's not just affecting the lungs, it can affect everything that the lungs are. Cause is unknown, possibly bacterial or essentially genetic anomaly. Possible causes could include an extreme immune response to infection, high sensitivity to environmental factors, and other genetic factors. Treatment-wise, they'll do steroid treatments to help decrease the size and number of lesions. In about 20% of cases, the pulmonary effects, so anything in the lungs, will not clear up with this steroid. Reading graphically, so about 90% of the time it will affect the thorax. You're going to see a 1, 2, 3 pattern with the lymph nodes. Essentially, you're going to have right hilar, left hilar, and right paratracheal nodal enlargement, or adenopathy. They'll do CT to demonstrate the enlargement of the nodes around the trachea. Actually, you really can't determine that with a CT. You can see the cross section. Check that out. High-res CT will also demonstrate the swelling of the lymph nodes and any sort of parenchymal disease that might also be involved. Coarse scarring will show up as irregular linear lines that run from the hilum to the edges of the image. It can also lead to severe fibrosis and emphysema, which can then lead to pulmonary hypertension and heart failure. So with some of these, you're also going to end up seeing, if you use those paratracheal lymph nodes and the hilar lymph nodes, most of the time they're very hard to see in X-ray unless they're super large, which is why we do that CT process to spot all those. So these are very, very large, which is why you're going to be able to see them. So there's a paratracheal lymph node, there's a right hilar lymph node, and then the left hilar lymph node. Very, very, very large. So stage 1, 2, and 3. You see a little bit of enlargement in those lymph nodes. In the hilar ones, you can't really see paratracheal. Stage 2, you start seeing that lymph node involvement more so, the enlargement of the paratracheal lymph nodes and the hilar lymph nodes. Some consolidation in the chest. And at stage 3, you're going to see a lot of that fibrosis already involved in both lungs. Here, you can see all that diffuse lung disease. Again, you can see all that fibrosis in the lungs. You see those air bronchograms. Here, those air-filled bronchioles. Very wide. Here, you can see all that consolidation in the lungs, and the cross-section of that air bronchiole. So subcutaneous sarcoidosis, you can see the scarring of the skin. Subcutaneous, you can see it right here. Annular. More like a ring pattern plaque. You can see a large area of a lot of little dots. So lesions are pretty much going to be on the hands and feet. You're going to see destruction of trabeculae in the bones. And then you see punch-out areas in the bones if the sarcoidosis has gone to the skeletal system. If it stays internal, let's say the stomach, you're going to see some masses in the stomach. You're going to see some narrowing of the lumens and the antrum in the stomach. Here's that bony pattern. See this. Punch-out appearance. It's essentially a hole punch. Punch-out section is long. And here in the skull. Okay. Pneumoconiosis. This is typically an occupational disease. People who have prolonged exposure to chemicals or other irritants, working in factories, manufacturing, things of that nature. This is a permanent effect. There's no cure or reversal for this. Essentially, you're just as we've seen in other things, kind of things like chronic interstitial inflammation. And in the advanced stages, you're going to see some very severe fibrosis. So if you look in this lung, you see all these black spots, are all those areas of fibrosis. The severity of the disease is determined by the size of the particle that was inhaled, or as much of the irritant that was inhaled, the length of exposure to that particle or inhalant, and the concentration of it. If it was way back in the day, we used asbestos for almost everything. If it was one asbestos particle, or if it was like 10, is what that means, the concentration. If it was small enough or not. There are three types mentioned, so there's silicosis, asbestosis, and anthracosis. So here there's that lesion in that right lung. So silicosis was the most common. This is the inhalation of silicon dioxide. A lot of concrete workers, masonry workers, there's a lot of silicon dioxide in those substances. So the dust that would be kicked off from mixing concrete, cutting concrete, things of that nature is what would be one of the causes for this. Acute would be developed within 10 months of exposure. This is a very accelerated growth, if you will, where it's about 5 to 15 years before they will know the disease progression. They may not show symptoms for that long. Chronic, they'll see about radiographic changes 15 to 20 years after exposure. Death usually occurs from lung or heart failure somewhere down the line. So this silicosis is an occupational lung disease. It is often fatal. So here are at-risk populations, so construction, mining, sandblasting, masonry, demolition, plumbing, painting. There's a lot of things that were made and no longer are made with a lot of these substances for this very reason. So continued exposure, they're going to have shortness of breath, fever, cyanosis. Become more fatigued, extreme shortness of breath, chest pains, respiratory failure as the disease progresses. So in all of these, you're going to notice kind of a similar thing. You're going to inhale that dust or whatever they were doing. It's going to get trapped down in that alveolar sac. It's not going to cause an immediate reaction to you. You're not going to notice anything. But slowly, the body's going to notice, hey, this isn't supposed to be here. And through the normal processes, like if you inhale something, it starts to cough to expel. A lot of these things actually get lodged in the tissue and won't be free. You can't cough it out, you can't do anything, it's just going to sit there. And over time, the body's going to keep attacking it to try to get rid of it. It's going to then create scar tissue, and that's going to build up and build up and build up. So radiographically, you're going to see some spherical nodules that look like they're very hard. They look like marbles almost, if you will. They will be of a uniform density. Mass formation is typically considered greater than 1 centimeter. They will tend to be up in the upper lobe. And it will give an eggshell appearance to the lymph nodes. Here, there's a uniform density. Here. Again, here's the lymph node that's got that eggshell appearance. See that very thin layer. That's off the interior. Again here, see that eggshell appearance, and then the thinner outer layer. Asbestosis is caused, as it says, by asbestos. Asbestos are, you can see these pictures here, very long, thin fibers. Once they get in, they'll lead to alveolitis and then fibrosis. And asbestosis can also then lead to mesothelioma. What happens with these, so when one of those little fibers gets inhaled, it then lodges itself typically in the bifurcations of the alveolar ducts. That then will cause the inflammation because the body's going to notice it, try to attack it, and it will then lead to inflammation and then alveolitis. Over long periods of time, it will then lead to extensive fibrosis, as you can see in the pictures here. There's a healthy lung. Here's the diseased lung. You can see all that fibrosis. Mesothelioma is irregular skeletal density in the pleural spaces. So you can see in this picture, we have the pleural space here. All that irregular density is then considered mesothelioma when it gets out there. It can also lead to pleural effusion. It is a extremely highly malignant. It can also lead to bronchiogenic carcinoma. That risk increases with smoking. You can see a shaggy heart sign. You have some round or irregular nodule pattern. You can see that calcification of the pleural lining and then the thickening of that pleural lining. So it's here right along the diaphragm. You have that pleural thickening, and along here, you have that pleural thickening. This is very early. So here's that normal heart shadow, and you have that shaggy heart shadow. You can see here the nice clean edges. You have that aortic arch, and down the heart here. Here you can't see. You barely make out the aortic arch, and then everything is just fuzzy. You can't really make out any delineation of the heart there. For mesothelioma, in this case, you're going to have pleural effusion. See that fluid level there, but everything else is essentially just all calcified out. Here fills all the base here. All these fibers are stuck. Causing those mesothelial cells to become damaged, and then they try to regrow and become cancerous. Here's what they're talking about, that irregular edge all along pleural space, inflammation and fibrous growth. Anthracosis, also termed coal workers disease or coal workers pneumoconiosis. This is typically caused by the inhalation of coal dust or anthracite. This kind of similar, instead of with asbestosis, the fibers getting stuck in the alveolar ducts. This actually affects the walls of the bronchioles. The ducts get stuck to the walls of the bronchioles, and that's where it essentially takes place. It causes the muscles to become weak in the bronchioles, where they are not able to dilate. This is also what is termed black lung. If you ever heard the term black lung, this is what it's referring to. Radiographically, you're going to see multiple small opacities with irregular densities, causing that particular pattern. They also then can develop into granular densities, or granulomas, as we heard about earlier, over time. The stent can also then lead to massive scarring. So as those fibrous areas where the granulomas keep forming, and keep growing and combining and growing and combining, you have these massive areas of scarring in the lung tissue. These masses, you'll see, can have smooth, well-defined borders close to the hilum. This does imitate bronchiogenic carcinoma. So here you can see that diffuse reticular pattern around the hilar area. You have a massive of the fibrous tissue, very hilar region. It also extends down to the right face. Here, we have areas of massive fibrosis, spoke about. Here's a blown-up picture of the one we saw earlier. The bronchioles are extremely dilated. All the area of fibrosis and fibrous tissue. Now you can see why it's called black lung. That's all the lung tissue. See how dilated some of these bronchioles are. There is no treatment. The particles that were inhaled, as with asbestosis, cannot be removed. Once they're there, they're there. You will have continued lung deterioration over. The best way to treat it is to stop the exposure. So if you went in there once, you were exposed, you don't have to go back. You guys, like you said, coal workers, that's going to work for years and years and years, and that's getting farther and farther developed. Moving to clean air, doing oxygen therapy, or if you actually live near the mine, move out of the area, move to a different area that really has very little air pollution. Mesothelioma may require lung resections, radiation therapy, or chemotherapy. That's really the only one of these that can be treated with that. Let's move on to some neoplasms.
Will there be radiographs for the test?
Yes. So I posted the study guide, if you guys haven't seen it. It has images on it to help practice, but it's not